Hi, welcome to Hub Bites. My name is Sanil Rege, consultant psychiatrist. Today I'll be taking you through the principles of psychiatric assessment and management. This is something that forms the basis of my clinical practice, and I also teach the principles of psychiatric assessment and management through psychscene.com and of course psychscenehub.com. So what is psychiatric assessment and management, and what are the key principles here? There are two key domains to think about. The first one is trying to get a good biopsychosocial understanding, but we can flash that out further and think about it as a biopsychosociocultural diet and lifestyle understanding. Now, once we get a good understanding of this can help us develop a good strategic management plan, and hence we move to the next stage of strategy. The reason why we think about the biopsychosociocultural diet and lifestyle understanding is because we can make sense of the patient's story to arrive at a formulation. So if we had to summarize the 4 key questions we think about when assessing a patient and then moving on to a management plan, we think about, firstly, what are the issues affecting the patient? Secondly, why have the issues developed at this point in time that are now affecting the patient? Next, how do I address these issues? And finally, what are the resources available and what barriers will I face when implementing a management plan? And why do we think about it in this manner? The reason is because we've got to think about DSM not as a definitive book that gives us all the answers, but we've got to understand the limitations around it. The DSM-4 is a cautionary statement that says, in DSM-4, there is no assumption that each category of a mental disorder is a completely discrete entity with absolute boundaries dividing it from other mental disorders or from no mental disorder. There is no assumption that all individuals described as having the same mental disorder are alike in all important ways. The specific diagnostic criteria included in DSM-4 are guidelines to be informed by clinical judgment and are not meant to be used in a cookbook fashion. The DSM-5 says it is well recognized that this set of categorical diagnoses does not fully describe the full range of mental disorders that individuals experience and present to clinicians on a daily basis throughout the world. Clinicians may encounter individuals whose symptoms do not meet full criteria for a mental disorder, but who demonstrate a clear need for treatment or care. The case formulation for any given patient must involve a careful clinical history and a concise summary of the social, psychological, and biological factors that may have contributed to developing a given mental disorder. Hence, it is not sufficient to simply check off the symptoms in the diagnostic criteria to make a mental disorder diagnosis. So therefore, how do we arrive at an understanding of diagnoses? One of the really powerful ways is to think about the hierarchy. When a patient presents to us, we start off from organic factors. This is then followed by substance use disorder. Now here we think of not only alcohol or illicit substances, but also medications that might be resulting in psychiatric symptomatology. Medication side effects, for example. The next level down is psychotic spectrum. Now this is not just about delusions and hallucinations, but also about mixed features, agitation, ruminations, overvalued ideations, mania, hypomania, all the way to delusions and hallucinations. So it's really examining the limbic system, the mesolimbic pathway, and the effects of increased dopamine in that pathway. The level below is affective disorders. Now here we think about the forms of depression, bipolar depression, unipolar depression, and whether it's milder or more severe type of melancholic depression. The level below is anxiety, trauma, eating disorder, and obsessive compulsive disorder. Now here, trauma does not only mean post-traumatic stress disorder, it also means past childhood trauma, but also current stresses. And finally, personality factors. So if I had to give you a quick example, if I was faced with a problem of treatment-resistant depression in a patient, I would know that treatment-resistant depression lies in the affective spectrum. I would then look at the spectra higher up, think about why the patient's not responding. So I would ask myself, is it possible that the patient has a bipolar depression? Is it possible that they have psychotic symptoms, overvalued ideations, ruminations, or delusions or hallucinations that might be resulting in treatment resistance. I go higher up, think about substance use factors, such as the use of alcohol or other illicit substances, or the possibility of medication resulting in depressive symptoms. And finally, higher up, I also think about organic factors, that is a range of medical conditions that might be resulting in depressive symptoms. I then go lower down to anxiety, trauma, OCD, and eating disorder. Now here I take a detailed trauma history and current stresses to see if this could be contributing or exacerbating depressive symptoms. And finally, think about personality elements. But I don't jump to the conclusion of a personality disorder if there are lots of higher level aspects happening in the hierarchy. Therefore, it's important not to jump to conclusions, and this hierarchy will help you take a structured history. Now, this is just the tip of the iceberg. What we then look at is what is the underlying foundation of the individual. And here we think of a range of factors. We think of biological elements, such as genetic factors, neurodevelopmental factors, other medical conditions. We then think of psychological factors, the presence of attachment disruptions, the presence of cognitive dysfunctional schema being developed during childhood, the possibility of a dialectical behavioral model such as pervasive emotional dysregulation due to trauma. We then also think of the socio-cultural factors. We think of finances, accommodation, relationships, vocation, cultural elements, and also any medical legal factors that might be playing a part. And finally, we think of diet and lifestyle factors. We think of diet, exercise, sleep, smoking, and alcohol and other illicit substances again. Now, once we get a good understanding of these factors, we're then able to arrive at a comprehensive formulation. Now, this formulation allows us then to develop a good management plan. And a good structured management plan goes like this. We think of risk and setting first. We then think of clarification of diagnosis through information gathering. We look at investigations. We look at the possibility of speaking to other individuals and involving other individuals to carry out certain assessments in that information gathering, help us arrive at a diagnosis, a more conclusive sort of understanding of the patient. We then look at treatment, biopsychosociocultural treatments, and once the patient enters remission or partial remission, we then enter the phase of long-term treatment. And this is divided into relapse prevention, drug and alcohol relapse prevention if those factors are present, and finally psychosocial rehabilitation, where we address the same things such as finances, accommodation, relationship, vocation. We then think of barriers to implementation that we might face, and then also think about the prognosis of the patient, something that we can communicate to patients and families. Now, you can visit psychinterview.com, where we've developed the Formulation Management Masterclass, and this masterclass runs for several hours through lectures, but also gives you lots of case studies and takes you through a lot more detailed understanding of how to develop a formulation and management plan. We hope that you found this lecture useful. Take care and stay safe.